Very good morning, rather good afternoon to all of you assembled here. It's my proud privilege to introduce such a stalwart of our country in quality journey, and his name itself speaks. Is Dr. Thuppil Venkatesh, and who has pioneered the quality control journey in the country, and not only as a professor and teacher of biochemistry, but at the same time, the still now he is going on with the organizing various quality control programs all over the country, mostly in South India, and as it is there, he was the Professor Emeritus of Biochemistry in St. John's Medical College, Bangalore, and as it is Quality Guru of Diagnostics, the Chief Architect of International Lead Assessors Training Program, and he has brought unleaded petrol to India during the year 2000 and has innovated several laboratory technology which are currently used across the globe, and he has delivered 8 special modules on behalf of IAS to the medical laboratory staff, and many of his students have started training centers in the India and abroad. Dr. Venkatesh has been instrumental developing a lead assessors course for NABL, AR, AR, SSC, PAO, and AMLA. He is founder and chairman of many national and international organizations. He has over 350 scientific papers and has contributed to many textbooks. Dr. Thuppil is the first Asian to receive the International Science, Truth and Honor Award in 2010, which is awarded 1 in 2 years, and is a recipient of Arjavat Award, recipient of Avades Saran Memorial Award, Seth GS Medical College Award, Thakur Memorial Award, Kaho Lifetime Achievement Award, and Lifetime Achievement Award, to name few. So I welcome Dr. Thuppil Venkatesh on stage and enlighten us regarding the present journey of quality in the scenario of CLIA and chemistry in medical laboratories.
Sir, 1 second, sir. We cannot hear you. 1 second. Okay. Yeah, sir. Can you hear us?
Yes.
Dr. Thuppil, sir, we cannot hear you.
Oh, Dr. Thuppil Venkatesh, please, you are welcome, and you can start your session.
Sir, we can't hear you. I think you are muted.
No, sir. We cannot hear you. Your voice is not coming. No, sir. We cannot hear you.
Okay, once
Yeah,
again.
yeah. Yes, sir. Now we can hear you. Yeah.
Am I audible now?
Yes, yes, sir. Yes, sir. Thank you.
Okay. If I am audible, please. Barnali?
Yes, sir. Yes, sir.
Okay, thank you very much. Sorry for this technical hitch. Okay, first let me convey my greetings to all of you in the capacity as one of the patrons of KAHO. Wonderful program and wonderful arrangement, wonderful speakers. I am from Bangalore. Unfortunately, I am not in Bangalore. I was in Delhi yesterday. Today I'm in All India Institute of Medical Sciences, Guwahati, from where I am addressing all of you. I am given a very, very interesting, challenging portion about which every one of you are aware. This is the pre-examination, post-examination errors. Now, I would like to tell you some difference between the non-conformance, non-conformity, error, and risk before I start. Anyway, are you able to see my presentation? Okay. Barnali, are you able to see the presentation projected?
Yes, sir. Yes, sir.
Now, laboratory errors. Why it happens? It is error is to human, and I would like to quickly take you through some few statements. The error, why this error happens in the laboratory. One second. Many mistakes in the examination process are called laboratory errors. In all activities, all procedures, processes, because of human. Although these may be due to poor communication, action taken by others involved in the examination process, including the physicians. It is not only laboratory people, even the physicians, the nurses, phlebotomists are involved in this. We think the laboratory people, all these are beyond our control. It is not so. In fact, a non-compliance, non-conformity, error, they have different meanings. You see, what is a non-conformity? What is a non-conformance? Non-conformance is yet to happen. It has not happened. Something which we are supposed to do, we are not doing. That causes an error. And potential source of error. Something which has what we should have done, we have not done, it becomes a non-conformity. That also is a evidence of an error. And what is the error actually, the mistake, or is because what we are not supposed to do, we are doing. That results in confirmed risk error. Therefore, before the error happens, if we get an idea, then it becomes a risk we can manage. This is, with this small background, I tell you, if you go to ISO 15189-2022, there are some 8 clauses. In the 7th clause, which is the process requirement, there are 3 processes or 5. Actually, there are 7.1 to 7.8. There are about 7 processes. In that, 7.2 is pre-examination processes. In that pre-examination processes, there could be error anywhere, which is avoidable, 100% preventable. But there are 7 places in the pre-examination process where error can happen. They are with relation to laboratory information for patients and users, or maybe request for providing laboratory information. Error can happen at the level of primary sample collection and handling. Error can happen at sample transportation. Error can happen at sample receipt. Now, when you see what I have seen when many people present, this is a slide I see, but I want to read in between lines. Now look at missing samples. This is quite common. Why it happens is because of lack of training, pressure, laboratory work pressure, many things. Sometimes the examination request itself will not have sufficient information, which leads to some kind of error which is introduced. Wrong identification of patient, not sample, patient himself, wrong identification, for surgery. Instead of right eye, left eye was operated. Instead of subject A, subject B was operated. Similarly, in the laboratory, wrong identification of patients because of common name and gender, etc. Wrong identification of samples. Samples are okay, right from the, but wrong identification. Contamination with infusion routes. This is this happens in the inpatients when they are in the ward, when some infusion is going on. Hemolyzed samples, clotted sample, insufficient sample. These are common things we see, and this also causes an error. Inappropriate container. I tell you, there are shortcuts adopted for the cost cutting. They prepare their own container. They are not properly prepared. No proper inappropriate blend anticoagulant ratio. I have seen people, to save money, they draw sample from disposable syringe and a needle and transfer it into vacuum tube where have some amount of anticoagulants. But the volume is not maintained. Inappropriate, this ratio, blood and anticoagulant ratio can cause error. Inappropriate transport. I tell you, I had to transport my son's sample to US for one test. And I don't know how safe it is, how environmental conditions are maintained, and inappropriate storage. This again because of lack of calibration, lack of training, concern. When everything is driven by money, finance, some of these things will get compromised. And procedure outside the lab thinks this is not our role. We have no control over that. These are all some of the pre-examination errors. And there is a point of testing now that 22870 standard is merged with our ISO 15189-2022. In this case, what is happening? Lab things, we have no control as non-laboratory staff carry out this examination at the bedside. It may be some nurse or maybe somebody, some staff paramedical doing this, but still there is a requirement as per the standard in Annex A, Annex 1, that there should be multidisciplinary committee to avoid this error which is related to point of care testing. Now, this is a mandatory requirement. Accreditation following standard may not be mandatory, but once we go in for adopting the standard for the purpose of third-party recognition, I tell you, all of us know that we have to have a control over point of care testing when there is a point of care monitoring. Earlier, point of care testing was a wave test. It is no longer wave test. We have to participate in external quality assessment schemes also, even for point of care testing. And here, one of the major issues I have come across, I have seen, when the IVD manufacturer, when they bring some change in their system or in their kits or reagents, when it is communicated to the laboratory which is using point of care testing, which is distributed to various clinical settings, it doesn't percolate. It doesn't get really, followed. As a result, there is an error here. The various types of error, the environmental error. The environmental errors are miscalculation that results from change in the environmental condition. Therefore, when we talk about environmental, it comes under one of the resources. Out of 8 resources, environment is one of the most important resources. If it is neglected, if it is not monitored, if it is not controlled, if it is not recorded properly, it is not reviewed, then there is an error. There is procedural error. No, we know that all the procedures, laboratory, in whichever section, whether pathology or molecular biology or biochemistry, all the procedures need to be accredited, validated procedure. And these validated procedures should be verified by the respective sections of the persons who are using. Then this is another one of the most common error. The causes of error in laboratory is the procedural error. This procedural error happens because of modification, the procedure without validating it, without verifying it. The procedures are borrowed from somewhere which is not checked. The procedures authenticity is also not established, especially in the molecular diagnostic. Throughout the COVID period, I tell you, left and right, every laboratory, whether they were trained or not, or equipped or properly or not, or whether supervised, the COVID testing went on and on. International bodies said the data from India is questionable. That's why they said they could come out with certain errors in some of the setup. Human error, it is unintentional. There's a human error is another which causes the error, an instrumental error where instruments are used because of the instrument condition, instrument maintenance, instrument calibration, they are calibrated for the purpose of calibration certificate to be produced to the assessors during assessment, not to use that K factor during the calculation. That also causes an error. Now, how do we prevent pre-examination errors? There are comprehensive plan to prevent pre-examination error. Means these are proactive and has 5 interrelated steps. One is developing clear written procedure. I always say you must have a documentation. That documentation is reliable. That documentation should be reviewed from time to time because the technology is changing very fast. Developing clear written procedures is one of the important tools to prevent pre-examination error. enhancing healthcare professional training. It's not only laboratory people who are involved outside the laboratory, who are collecting samples, who are transporting samples, who are preserving samples, who are separating samples. These are the people. This kind of training is also very essential. The third important prevention tool is automating functions. Of course, the laboratories are going into robotics, artificial intelligence to reduce. I'll tell you the percentage of errors we come across in this pre-examination phase, both for support operations and for executive operations. Here, the IVD industry, like Mindray, is playing a very big role. They are a great support for all the laboratories to reduce the error. I tell you, if technology or the IVD is one side of the coin, the other side of the coin is experts in the laboratory, the knowledgeable persons with competence, and monitoring quality indicators. If it's properly done, then number of errors can be brought down. This quality indicator is a key performance indicator, and also the error which is going to happen can be prevented to a large extent. And also, apart from this, the fifth one is improving communication among healthcare professionals and fostering interdepartmental cooperation. There are a lot of references on this. Lack of time, I will not be going into the details. And this communication could be verbal communication sometimes is not heard properly or forgotten. Therefore, right type of communication. Today we are going in for communication era. Why did we change from 2012 to 2022? Version is one of the main reasons is nano information technology. Technology is also fast changing. Artificial intelligence is getting into this. And this is one of the prevention of pre-examination errors. When you look at pre-examination, inappropriate test requests, order entry errors, misidentification of patients, container inappropriation, sample collection and transport inadequate sample, anticoagulant ratio, whatever I told you, leads to somewhere up to 68.2%. This is published in many international journals. 46 to 68%. This is in accredited laboratories which are certified by third party. Forget about the other laboratories. I'm not commenting on that. Accountable laboratories. These are all, legally recognized, ethically following all the system. There, the error goes up to that. However, in the examination area, because of automation and because of the system, which are all highly validated, the error is only 7% to 13%. When you come to the post-examination phase, the error, there are only one important thing in post-examination phase, that is the reporting of results. Therefore, failure in reporting, errors, validation of an analyte, erroneous validation. You see, laboratory manufacturers or producers the patient result. That is the only thing which is supplied as a service to the users, clinicians, and that has to be validated. Like your industry validates what they provide you, but it has to be verified by you. Similarly, what we generate, what we manufacture, what we produce, the service we provide need to be validated. That's where the IQC and EQ, all this comes into picture. That comes in the examination phase. However, in the post-examination phase, these are the two. Failure in reporting and erroneous validation of analyte leads to somewhere between 18.5 to 47%. Look at the error in the pre-exam and post-exam. I don't know why the organizers wanted me to talk on pre-exam and post-exam only. Yes, because they know very well the percentage of error contribution in the examination phase is only 7% to 13%. This is coming down with full automation these days. The post-examination errors, with a limited time given to me, I am trying to consolidate. The common post-examination error include failure to report test results. Results are there, some reason are there, maybe justifications are there, failure to report test results. Now, root cause has to be found out. Unless we do that, it cannot be corrected. Delay in reporting. I tell you, this has caused a lot of problem to the clinician treating the patient. I was waiting for some reports I'm yet to get, but I don't know what to do. Suffering goes on with the patient. Delay in reporting and incorrect calculation. This is another major issue, because today some laboratories, I'm told, they get about 20,000 samples a day. And imagine with a limited staff, in spite of very high-end computer technology, 20,000 samples. Documentation and verification is a big challenge. We always depend upon the technology, and technology can fail, misguide us. That is incorrect calculation. Critical results not reported are maybe delayed and results sent to the wrong patient. This is one is result is correct. Everything is fine, but it has gone to some other patient. The patient who is supposed to get this is not getting it. Causes of post-examination error in general. Such post-examination error, I'm generalizing it to all the departments is applicable. I may be from biochemistry background. I have forgotten my biochemistry. Forget about that. But this is general to all the sections. For example, entry. At entry level, are we checking? Is it possible to check? Even computer system, do we have a system, inbuilt system to check the entry? Firmware, are we using it? Manipulation. This is something which is unacceptable, which happens. I am not saying it's you are doing or I am doing it. We have come across this happening. Reporting of test data. This is where the post-examination error occurs. If results are written by hand or entered by a keyboard, then an entry error may occur. Errors in data transmission, including relying on hearing verbal information incorrectly, and this, unless it is repeated, is the cause of post-examination error. And how do you reduce post-exam error? Suggest an appropriate response. For example, suggesting further investigation, not necessarily a laboratory examination, or referral. Promote best practices. Now, today I was giving a talk an hour ago on good laboratory practices. I said it should be changed to good life practices, not laboratory practice. Life practice, wherever we are, it should become a habit. They promote best practices in day-to-day life. That helps to a large extent. Promote clinical action. Avoid misinterpretation. These are the ways to reduce post-examination errors. In this post-examination processes include the alignment of the raw sequence data using a reference human genome followed by a variant identification with corresponding clinical interpretation, clinical decision work. Externally, quality assurance program for the post-exam fields have to be introduced. This is a mandatory requirement recommended. We are now we have married to CLSI from India. We get all their documents at the 1/10 the price and membership 1/10 the price, and there are documents pertaining to the errors in the laboratory errors. Maybe you can avail those facilities. Here is human building a safer health system. It is there 1999, way back. The 8th leading cause of death is 44,000 deaths per year. And here is human building a safer health system. The Washington DC National Academy Press in 2000. Please go through that. We get a lot of information. I have given a general, introduction to this whole workshop today. Thanks to Mindray for taking up this. I tell you, we are all responsible. We cannot shirk our responsibility. We have to be very, very cautious, meticulous. Then only we be proud of ourselves that we are part of healthcare system. This is my personal, last view. And I am in the evenings of life. Most of you in the mornings of life. If I am the setting sun, you are all the rising sun. You have a lot of time, greater opportunity to avoid or correct the mistakes we made, our generation. Friends, I wish all of you all the best. Thanks to our Jairam, Barnali, our other colleagues who have invited me at this age. And I wish I was there with you in my hometown. But unfortunately, I'm missing all of you. I wish you all the best. Thank you very much.
Thank you very much, sir. It's a nice, vivid account of almost minute by minute account of the flow of work in the laboratory. And of course, you have raised a lot of issues. And maybe I feel most of the participants should be having some of their queries in their mind. And I would request, sir, to enlighten if our participants having any query both on site as well as online, and I request the participants to raise any queries if you want to hear from sir, about any account of it. Welcome, participants.
Good afternoon, Dr. Jayalakshmi.
So, are there any questions for Dr. Thuppil?
Can
Yes.
I ask one question, sir?
Please go ahead.
Thank you, sir. Thank you for this excellent talk. Your quality journey is so inspiring. So my question is regarding POCT, like you mentioned in the slide, because now POCT is POCT is a big thing, and we always we see during our hospital quality journey that we follow for our analytical instruments, everything verifications and everything, quality control, like you see QA. But most of the lab, in POCT, you find lot of challenges from glucometer to the POCT instrument in from ABG to everything used in the hospital. So, sir, how to how to follow the checklist and how to do
Okay.
insight.
Very appropriate question, Barnali. I really like this question. You see, there are two standards which laboratory must keep with them. One is the International Organization for ISO Technical Standard 22583. If I remember correctly, I don't know, my memory may not be right. Technical Standard ISO Technical Standard 22583 provides guidance for non-laboratory supported services. Okay. POCT is also one of them. It's a non-laboratory provided supported service by others. ISO 15190. Please remember, again, it's a medical laboratory standard, which is for medical laboratory environment and safety. And ISO 22367, that's another standard, provides guidance on safety and risk aspects of POCT. We are talking about risk, error, risk, error,
Yes.
risk. Therefore, these three standards, ISO TS 22583, ISO 15190, ISO 22367, if these three standards are understood by POCT committee, the POCT committee is the committee wherein you have laboratory representative, we have representatives from the clinicians, nurses, management, because they share the resources, financial resources also. Therefore, service agreement between laboratory and all locations using laboratory supported POCT shall ensure that respective responsibility authorities are specified, documented, communicated within the organization. This is number one. This will solve most of the problem. Apart from this, these agreements shall have clinical approval, like your ethical approval, clinical approval, and where applicable, financial approval, because the finances are required. And also we should remember, the service agreement shall be with POCT area and may be managed by a health professional grouping, like medical advisory committee. This is another important requirement. And finally, I would like to tell you, quality assurance program is the backbone of POCT, and training program. A person with appropriate training. Who is going to train? The trainer. The person with appropriate training and experience shall be appointed to manage training. That is very important. Manage training and competency assessment of personnel performing POCT. If that is done, Dr. Barnali, I tell you, the error will be very, very limited or minimal. And finally, the trainer shall, like you and me, we should develop, implement, maintain as appropriate both theoretical, practical training program for all POCT personnel, where we should involve the industry also.
Thank you, sir. Thank you.
That's your question.
Absolutely. Thank you, sir.
Any other questions from the audience, please, for Dr. Thuppil?
I'm extremely sorry. I apologize. I am missing all of you in physical presence. Pardon me for that.
So my question related to the POCT, glucometer user. How you train the people who use the glucometer at home and how they manage the quality for the glucometer?
Okay. I will give you an example. In the Cleveland Clinic in Abu Dhabi, they have 200 and plus glucometers. There is one dedicated officer put in charge of only glucometers. His job, he has a small room. Every day he gets some 10 glucometers, validates, verifies, sends it, and brings some people, train them. There should be a dedicated the point of test managing person. That person is the key person. This is requirement. Future, I tell you, the whole laboratory is going to become POCT. Next 10 years to come, most of the examinations conducted will be through POC. Take it from me. All these big missions will become smaller and smaller to a matchbox size.
Good afternoon, sir.
Yes, good afternoon.
See, you are talking about the pre-analytical and post-analytical errors.
Exam and post-exam. We don't use the word analytical now.
So, while we are monitoring quality, mostly our systems are for analytical quality, whether the accuracy or equa. So, while you are moving through your evenings, do you have an idea in mind how to monitor this pre-analytical and post-analytical errors?
Please repeat, George, I could not get it clearly.
See, most of our systems are just for analytical quality monitoring, whether it is an accuracy or equa. So this over the years, we did not find any system for monitoring the pre-analytical or post-analytical errors. So do you have, after as long as you are moving to your evenings, so can you have any suggestion for us to monitor those type of errors?
My suggestion is only to understand this much clearer is to follow this 15189/2022. That gives you complete solution for a laboratory management to even look into the errors in any aspect of laboratory activity. Therefore, my strong suggestion is, before regulators come, let us regulate ourselves. Before somebody comes and asks, are you accredited? Are you going in? Let us go in for accreditation.
Thank you, Dr. Thuppil. I feel now there are no more questions from the audience too. So may I request Mr. Sudeep Mukherjee to please hand over the certificates to our chairperson and our honorable speaker. May I please request Dr. Mohanty to... Dr. Mohanty. Dr. Thuppil?
Yeah, I'm here.
Yes, sir. So your certificate.
Okay.
We show it to you.
Thank you. Thank you very much.